Good afternoon, everyone. You are all very welcome to our Sláintecare webinar. I'm Gráinne Healy, and I'm delighted that you've joined us for today's session. This Sláintecare webinar is the 24th in the series, and we're really delighted to be delivering it in partnership with the HSE. As always, we are very happy to take questions or comments from you, the viewers. Just use the chat function and I will convey your remarks or questions to the panel of guests with us this afternoon. You can also join the conversation on X, formerly Twitter, using the handle @Sláintecare or the hashtag right care, right place, right time. Sláintecare is about delivering the right care in the right place at the right time by the right team. And today we're focusing on the recently published Sláintecare Progress Report. This report highlights the progress being made in transforming our health and social care services to provide the right care in the right place at the right time. Within the hour we have today, we'll focus on only a small slice of what has been achieved, and we will come back to some of the areas not covered today in future webinars. Today, we're going to look at the new health regions, modernised care pathways, and enhanced community care. I am delighted to be joined by Grace O'Regan from the Sláintecare Programme Management Office, who will take us through some of the progress in delivering Sláintecare over the last 3 years. But first, Grace spoke to Robert Watt, the Secretary General of the Department of Health, earlier in the week to hear his views on the progress to date. Let's hear from Robert now.
Robert, thanks for taking the time to meet.
Pleasure, Grace, pleasure to see you.
As you know, we were doing Sláintecare Webinar on Thursday, and the webinar is focused on the progress that's been made through Sláintecare, this report in Sláintecare Progress Report from the period 21 to 23, which is the second period of Sláintecare implementation, the first being 2018 to 21. And we're very interested in your views as leader of the Department of Health since 2020, with your experience in public service reform going back many years in Ireland, but focused on the progress in Sláintecare, which is the most significant reform programme undertaken in the health sector in Ireland to date, and probably the largest public sector reform programme in the history of the state. What do you consider to be the most significant aspects of this reform programme?
Well, I think, first of all, it's great that we're having this webinar to mark the publication of the Progress Report. And within the Progress Report, it sets out very detail all the different steps that have been taken, the measures, the initiatives. And I know there are many people on this webinar who are involved in that. I'd like to thank them for all their effort. I know that reform can involve changing the way we work, changing our practices, bringing people with us. It's very involved, it can be very contested, very difficult. So people, I think, on these occasions should mark and note the success of the reform programme, what we've done, and it's great to see the progress that we have made. When you look at the many different aspects of this in terms of workforce reform, digitalisation, elective hospitals, there's many aspects to it. So it's a really multifaceted programme which straddles over a number of years. Sláintecare was published, I think, in 2017, 2018. So this is taking a long time to deliver, and we've much more to do. It's very hard to pick out particular things that have been very impactful because all aspects of it are important and collectively lead up to what we're seeing in terms of significant improvement for patients. And that's what it's about. We are seeing this year, as we saw last year, a significant increase in activity. The number of people being seen by their consultant for the first time, the number of people benefiting from a day case procedure or an inpatient procedure has gone up. And we're also seeing progress in relation to trolleys. Despite an increase in admissions and presentations, we're seeing the numbers of people waiting for trolleys, even though too high, the numbers are coming down. So the impact we are seeing in terms of patient outcomes and those key metrics about how long people are waiting for treatment and then how quickly people can access hospital care and emergency, they're key metrics, and we're starting to see some impact. So I would say, I would highlight two, and I could pick any of the many different projects, so it's difficult to pick a few, but I pick out two. I think the Sláintecare contract, and we're already seeing now, we've over 2,200 people who've signed up to the contract, more than 50% of the consultant body. We are seeing the availability of decision makers in the evening and at the weekend. And we're seeing, just to take one example, a very significant increase in discharge rates for the hospital system on Saturday. I think about 30% increase. So that's the consultant contract, and that's only begun in terms of how it's implemented and impacted upon the service. But the consultant contract is already starting to have an impact in terms of improving patient outcomes, and that's great to see. And we have a lot more to go. So I think that's one, great achievement, and particularly thanks to our colleagues in the HSE and our colleagues in the Department of Health, who spent a long time negotiating with the IMO and the IHCA. And I think we have a contact now that we can really build on to improve outcomes for patients. The second program, which I guess is probably different and longer running, is the enhanced community care. And we're seeing many different aspects of this program, but just to take the chronic disease management, citizens with particular conditions, they're being managed now, community, GPs and consultants working together and providing continuous care away from hospitals and close to people's home. And the ECC, in many different aspects, and that's just one aspect, the CDM, is having a very significant impact. So I think those two programs, I think just to mention two, but of course the elective programs, the digitalization, changes in scope of practice, all the different aspects are having a collective impact on improving the health service for our citizens.
Okay, great, thank you. Digital data and innovation are key enablers of any public service reform programme. How are these elements enabling delivery of Sláintecare to ensure our health and social care services are future fit? And what difference will they make to the patient experience as well as patient outcomes?
So I think we've seen some improvements in terms of how we share data, certainly during COVID. I think that was a very good example of how we can use the app, the technology, by sharing data to provide the rollout of the vaccine very quickly for citizens. So we are seeing a number of applications which are starting to have an impact. And just to pick a few, the virtual wards, the community virtual wards and the acute virtual wards, where people are treated remotely and treated close to home, those sort of innovations are starting to have an impact. But I think it's fair to say, and I always hate being critical, but I think it is an area where we're not doing as well as we could be doing. And we need to do much better when it comes to data sharing, when it comes to digitalization. But today, and I'm recording this chat on Tuesday, I know that the webinar is on Thursday, but today the government have approved the new digital strategy, and that has a number of different elements. And just two elements to pick out, which I'm particularly excited about. First of all, is the patient app, and we have several hundred people now who are testing the app for us, and we're hoping to disseminate that, have that widely available then throughout the middle of this year, and that will provide people with, on their phone, basic information, their ID, their various health conditions and so on. But over time then is to develop a national care shared record where we will see on our phone our care journey. When you interact with a GP or a community service or acute hospital, the app will update, the record will update. So the next time you meet your consultant or your GP or nurse, they will be able to see your latest interactions, along with details around your conditions, about your prescribing patterns, around other things that are relevant for your care. So I think we can do much better. And I think that's exciting because there's great potential, great opportunity. And I think it's part of this wider discussion we have about productivity, about the need for us to improve productivity. Certainly practitioners in the system tell me that if they can spend less time accessing the information on a patient, interacting with their colleagues about a patient, and if it's all in one place, one record, one repository, well then that can really improve efficiency. So the digitalization, the data sharing, I think that's an area where we all individually and collectively need to do better. I think we now have our roadmap. The government have approved it today. We need to get the funding, but I think we have exciting opportunities to improve patient care through better use of data and digital technologies.
Okay, great, thank you. And then finally, how is Sláintecare enabling the health service to deliver the best health outcomes for the people who use our services?
Well, I suppose it's about improving access to care. And I mentioned earlier the waiting lists, and also then in terms of unscheduled care challenges. So Sláintecare in all its different dimensions, and I've touched on a few of them, the ECC, the digitalization, the consultant contract, it's all about improving the volume of service, providing more service, better services, safer services for the citizens. And I guess in our mind all the time, it's about how do we do more? How do we do more with the same? How do we accelerate each year to have more activity? Because we've got 500,000 people waiting for an outpatient consultation. That's too many. They're waiting too long. So we need to change how we work, change how we interact, change the way in which we engage with patients to ensure that we can do more. So ultimately, the success of Sláintecare is how we increase the overall activity in the public health system. More activity, but of course safer and better care for people. And that's in the context of the weightiness that we have and the legacy challenges in the system, but also in the context of the fact that we have very significant demographic change. And this demographic change means the current model of care is not sustainable, and we need to develop new models along the lines that we have set out in Sláintecare. And I think it's really, Sláintecare will enable us to ensure that we can provide the best possible care to people in Ireland, to our citizens in Ireland, particularly as we go through this demographic change over the next 10, 15 years.
Okay. That's great. Thank you for your time, Robert.
Thank you very much.
Thank you indeed. So it's great to hear from the Secretary General there, and in particular, I think his understanding of the great efforts that staff have put into delivering Sláintecare, driving, as he talks it, driving towards more, safer and better and more accessible services. Grace, thank you so much for doing the interview with himself the other day. You're very welcome to the webinar this afternoon. I'd like to invite you now to outline some of the background, the context, and the key highlights of progress delivered over the last 3 years under Sláintecare.
Great. Hi, Grania. Thanks for that. I'm just going to share my screen. Can you see the presentation?
Yeah, all good.
Excellent. Okay. Good afternoon, everybody. I'm delighted to be here. As Grania mentioned, I'm from the Sláintecare Progress Management Office. I'm going to take you through a very quick, high-level overview of some of the highlights of the progress that has been made over the last 3 years. To begin with, though, I think it's worth just taking a moment to consider where we're at in terms of Ireland's health trends and overall performance. And there's a number of facts I want to just bring to your attention, which you may well already be aware of. As you may know, Ireland has the highest self-perceived health status in the EU, with 80% of people rating their health as good or very good. Ireland is among a group of 7 EU countries where life expectancy is above 82. Now, Robert mentioned our demographics. We know that between 2012 and 2022, our population has grown by over 10.3%. We know that our population is aging. The portion of people over the age of 45 is aging. This obviously has implications for our health service, particularly into the future. And if you just look at the funding, a very significant amount of funding is now being invested in our health service. In 21, we spent approximately 3,800 per head on health, which is nearly equal to the EU average, and public sources funded 77.4% of health expenditure, which is a share just below the EU average. As Gordon mentioned at the opening of the webinar, Sláintecare reform is about providing the right care at the right place at the right time, and increasingly we're seen by the right team. Sláintecare aims to broadly do 3 things: to broaden the coverage of universal care, to decentralise provision, and to enhance the integration of primary, community and hospital care. Now, as Robert mentioned, the reforms are complicated. The programme is very broad. It covers a number of very important aspects. And it reflects a healthcare system that the OECD has described as complex and opaque. And whereas other European states over the course of the 20th century introduced and developed universal systems in which access to care was guaranteed, in Ireland, we developed a 2-tier system for various reasons. We won't go into them now. But this brings me to the background to Sláintecare. Now, what we have since 2017, when the Oireachtas Committee on the Future of Healthcare published its report, which was groundbreaking in terms of all political parties coming together to agree their long-term vision for health and social care and the direction of health policy in Ireland. That vision being to achieve a universal health and social care system where everyone has equitable access to services based on need and not ability to pay. What we have seen since is in 2018, government policy was formally published as the Sláintecare implementation strategy that covered the period 2018 to 2020. And this started what has been the most significant reform programme in Ireland's health sector and one of the most significant public service reform programmes in the history of the state. So the first implementation programme, the 2018 to 2020, we see that very much as the initiation phase of Sláintecare, and a number of very important first steps were taken during this phase, including the establishment of the independent HSE board, government approval of the geographies for the 6 new HSE health regions, establishment of the community healthcare networks, the integrated care hubs for older people and people with chronic disease. So very much the building blocks that we now see as part of the enhanced community care programme. And importantly, the investment in Healthy Ireland and in public health promotion, including the obesity policy and action plan, the national physical activity plan, the sexual health strategy, and other related health promotion strategies. So that's the background to the point to which we're interested in highlighting today, which is the progress that has been made over the period 21 to 23. Now, as we've mentioned already, the programme is broad, it's complex, it covers a number of very important aspects. There's two parts to the programme. The first part focuses on improving safe, timely access to care and promoting health and wellbeing. Reform Programme 2 looks at addressing health inequalities. There's 11 projects over the course of the two programmes. I'm not going to go into all of them in detail, but just to mention a few. Project 1 implements the health service capacity review, which was undertaken in 2018 and looked at the supply and demand in terms of services in health and social care services. And out of that, we've 3 work streams. One around healthy living, the Healthy Ireland programme. Enhanced community care fits within this part of the programme, and in itself is a very significant programme. I think that's probably the thing to note about Sláintecare. It is a huge programme with some very significant programmes within it. Hospital productivity. Just to pick out a few more, Project 3, streamline care pathways from prevention to discharge. That's Modernised care pathways. We have an example of that coming up later in the webinar. Project 5, Robert spoke about the waiting lists. The implement a multi-annual waiting list reduction plan it fits in there. Project 7 is remove private care from public hospitals. Implement the Sláintecare consulting contract. I'll go into a bit more detail on that later. Programme 2, addressing health inequalities, just to mention one. Project 3 is develop regional health areas. We're going to be hearing from Tony Cannon in a moment in relation to that. It is important to mention the investment that's been made in both Sláintecare and in the overall health service in recent years, and this has been a significant driver of the success of the programme to date and the progress that we're able to report on today. Since the programme for government, 1.235 billion was invested in 2021, 2 billion over the course of the last number of years. More broadly, the reforms have been supported by government expenditure in the overall health and social care service. We can see there's been a 34% increase in expenditure between the period of 2018 to 2024 of these 6 years. The amounts invested have jumped from 16.8 billion to 22.5 billion. And if we look at acute care, the investment has increased by more than 80%. So to get into the report, this is it. You can access it online. It's an interesting read. I'm going to pick out just a few highlights. As Gordon was saying, there's a lot within it. So you can't cover everything. So just to mention a number of them here. Waiting lists, we've seen that they're down for the second year in a row into 2023. There's been a 32% reduction in patients waiting longer than 12 months in 2023. The number of patients on trolleys in 23 is down versus 22% reduction. There's now 174 primary care centres. So the capacity is being built and access is being improved. In terms of eligibility and affordability, there's more people eligible for GP access cards and medical cards, and new services have been introduced, including the IVF was rolled out in 2023, free contraception. If we look at how we've increased capacity to meet the needs of the growing needs of our growing and ageing population, there's been a number of capital projects, just reference a few of them here. The new elective hospitals, Cork, Galway and Dublin, they're in various stages of planning. Once these are established, we will see it's estimated there'll be 1 million new procedures, elective procedures possible within the system, which has been described as a game changer into the future. The National Forensic Mental Hospital has opened, major trauma centres have opened. In terms of capacity and our workforce, the workforce numbers have increased from 120,000 in 2019 to over 140,000 at the end of 2023. GP places, training places have been increased. There's more student places across numerous health care disciplines. If we look under the reform category, the HSE Health Regions, we're going to be hearing from Tony about that in a moment. The public winning consulting contract, I'll go into a little more detail there. The HSE patient app, Robert talked about how this will make a difference to patient interaction and the engagement with clinicians and how it should increase efficiencies and improve the patient experience. Quality and Safety, the Healthy Ireland Strategic Action Plan is published for the period 21 to 25. Throughout many of the Sláintecare programmes, and indeed in the development of the new programme, which we're finalising at the moment, there's been extensive stakeholder engagement. So just very quick deep dive into a number of the programmes. The waiting list obviously is a political priority. To give you a bit of context, between 2015 and 2021, our scheduled care waiting list increased by nearly 60%. So in late 21, the Minister of Health implemented a multi-annual approach to reduce hospital waiting lists and waiting times. And as we can see, in 23, our health service treated many more patients and exceeded the target of 10% reduction in the number of patients exceeding the Sláintecare waiting times. And you can see some of the numbers illustrating that there below. So there's a number of new ways of delivering care being implemented through the waiting list action plan, including modernised care pathways and surgical hubs. I mentioned expanding eligibility earlier. There was a number of measures taken over each of the years 21, 22, 23. You can see them there, including income thresholds for medical cards for those over age 70 were increased, expansion free GP care to children aged between 6 and 7 in 2023. There's more mentioned there. The effect of all of these cumulative measures and expansion mean that more than 50% of the population now have access to medical cards or GP cards. Robert mentioned the public-only consultant contract. We just have included this graph so you can see that the increase in the level of uptake. We're anticipating, he mentioned some of the benefits that we're already seeing from these new contracts. But these cumulatively, what we will see is this will help us to maintain efficient and timely patient flow out of hours and the weekends, and it should reduce waiting times by maximising capacity of our hospitals. As I mentioned, we're formulating the new Sláintecare strategy for the period ahead, and I can go into a bit more detail maybe at the end, but I'll leave it there, Gwen. Thank you.
Superb! What a whistle-stop tour. Get your breath back there, Grace. That was a great dash to the line. Well done, thank you. And I think it's wonderful, as we've seen on this webinar series, such significant progress. And I know it's difficult to cover everything in detail in such a short time. And as I said in the introduction, I do hope that we will get back to looking at some of the key highlights that we haven't been able to deep dive into today. But thank you for that, Grace. And Grace is going to join us later for the panel discussion. Just to remind everyone that the Sláintecare Progress Report is available to view or download from the website. So if you're interested in having your own deep dive into it and learning more about the delivery, please do go to the Sláintecare website and download it there. Now, as most of the viewers will know, the health regions reform involves the reorganisation of the HSE into 6 operational regions with responsibility for the planning and coordinated delivery of health and social care of their respective populations. This is a foundational action for the implementation of the Sláintecare project. I am delighted to be joined now by Tony Canavan. And Tony is the Regional Executive Officer for one of the health regions in the West Northwest. Tony, you are very welcome. Thank you so much for joining us this afternoon.
Thanks, Colin. It's great to be here.
So our health and social care services are being restructured through the establishment of these health regions. Can you tell me, Tony, a bit about, what stage is this at and how will the new structure enable integrated care?
Yeah, well, we're at the stage of establishing the regional health area management teams. So in addition to myself, there are 5 other colleagues, one for each of the 6 regions, appointed starting in December, then through January. Excuse me, 3 of us in March, and then the 6th and final person in April. So all 6 of the regional executive officers are now in post since around the middle of April. And we've been, I suppose, trying to prepare the population then of the regional health area management team. A key part of that, key members of those teams would be integrated health area managers. And last Friday, it was it was a really important day for us in a way because we got those integrated health area manager posts, we got those advertised. So they're out to competition, and we would be hopefully seeing plenty of interest in those posts over the coming weeks with a view to interviewing by the end of June. We're also, yeah, it's good progress, and we're progressing hopefully with further advertisements of maybe the finance and HR positions on those teams tomorrow, and then with further advertisements the following week, and trying to build up momentum over the coming weeks. So a lot of our effort has been focused around trying to get the regional health area management teams in post. And while we've been doing a lot of work in the background, I think we're starting to see some of that now come to fruition over the most recent weeks.
Great. And of course, all of these stepping stones, putting the infrastructure in place, are really important if we're to have a robust in the 6 regions. What difference will these regions make to patients and people who are accessing the health and social care services?
So first of all, I think that we're already starting to make a difference, and I think both Robert and indeed Grace have referred to that. So I think we're already starting to see that difference happening. At the most global level, from a service delivery point of view, I guess what we will have is a much better integration between the various places through which care is provided. We always talk about integrating hospital and community-based services, and that's really important. Every patient that comes into a hospital leaves the community and hopefully returns to it afterwards. So having that connectivity is really important, but also integration within our hospitals and between our hospitals, but also within our community services between primary care and mental health is also really important. So I think getting that type of integration under the new regions will yield real benefits for patients, without a doubt. I think the other key difference that it'll make, and this is probably one of the fundamental principles, is that it'll bring decision making back closer to where care is delivered. And we're part of since 2004 we've been part of a national HSE, a national organization, and there were good reasons for that, and indeed a lot of good was achieved through that. But in order for us to really, I suppose, develop ownership of our health services at regional level, we have to bring that decision making back out, and that's one of the big promises of this restructuring.
And tell me, what difference does it actually make if the decisions are being made locally? Is it that it's faster? It's quicker to response? Simply put, is that what it is? It comes down to that.
There's a number of different aspects to it, but you're absolutely right. If we can bring the important decisions close to where patients receive care, then it can become more timely, so that the people that are making the decisions can do so in a way that really, in a time frame that makes sense for patients. But more importantly, I think the actual quality of the decision itself becomes more connected to the patient's needs, and that is a really, really important step. It allows our staff to feel that they're part of something that's really important and worthwhile, but it also allows our patients to become active partners in the delivery of care. And that's an important principle behind Sláintecare as well.
Yeah, very good. So there's a lot of change happening as we progress towards, as you say, they've already started, but the full operation, all of those posts in place. How do you manage that change and at the same time continue to deliver the services? Is that a challenge?
Oh no, it absolutely is, and it's no harm for us to remind ourselves and to remind, people that use our services that the health services operate 24 hours of every single day of the year. That they have to. That is how we function, and that is the service that we provide. So the option of taking a pause, so we can do a little bit of restructuring, that's not an option. So we do the restructuring while we're continuing to provide the best care that we possibly can to every single patient on every day that we're involved with them. So I think we're lucky. We've got really good staff and really good, within that, we've really good managers and really good clinicians, and all of those people are in place currently, and they're very focused on making sure that the job that they're doing today is, as good as it can be. There are a number of us then that have maybe the privilege of being able to step back a bit like myself. My job at the moment is about trying to get this new structure in place, and it's more about that than it is about delivering operationally each day. So I think our staff is the greatest asset in that regard, keeping a close eye on the day-to-day and making sure that it's done right.
Very good. So Tony, in brief, what will success look like for you?
I was really impressed with Grace's first slide, because I think success has to look like the things that Robert described. It has to look like improved access through the emergency departments and through the waiting list and all the rest of it. But actually, for me and for our region, one of the real measures of success has to be around the health of the population that we're serving. Again, this regionalisation of our services, it gives us an opportunity to actually look at are we making a difference, a measured difference in the health of the population that we're serving? So that's why I was really impressed with Grace's first slide. You know, she was referring to, you know, the state of the health of the Irish population. That's a really important measure. I'd love to be able to look back in 5 years and say we made a real difference and we can measure it.
Brilliant. Well, the best of luck with it, Tony, and thank you so much for joining us this afternoon. And I know you're rushing off to another meeting, so we really appreciate you giving us the time. Good luck with the work. Thanks, Tony.
Thank you.
Modernised care pathways are a key deliverable underpinning action on the waiting list action plans, a necessity of integrated care delivery and a building block for the regions that Tony was just talking about, these new HSE health regions. I'm delighted now to be joined by Dr. Geraldine Comer, and Geraldine is a consultant medical ophthalmologist for Community Healthcare West Galway, and she is the lead ophthalmologist for the Galway Community Integrated Eye Care team. Geraldine, you are very welcome. Thank you so much for joining us this afternoon.
Thanks very much, Roy.
No, it's great to have you. Geraldine, would you start? I know we have some slides, we'll go through them. Would you talk to us about the background to this new ophthalmology modernised care pathway in Galway and the problem that you set out to solve by this new initiative?
Well, I took up my post in May of 2023, and prior to that, there was a huge volume of children on the waiting list for community eye clinic appointments. And the reason for that is because the eye team just was very small. There weren't enough clinics taking place on a weekly basis. There weren't enough children being called. So there were about almost 4,000 children waiting for their eye appointments. And a large number, 1,700 or in excess, were waiting over 18 months. And actually, some of these children were waiting up to 3 to 4 years for their appointments. So really, the first port of call was to deal with this waiting list, which was so extensive. And really, that was our first, our initial role, shall we say, our initial what we went to achieve.
To do. Gosh, and that is a lot of children, isn't it? Waiting, and particularly waiting for more than 18 months. So how have the service been restructured then to address the problem?
Well, straight away, we dived in and we set up our community eye team. So this is myself leading it, and I have 3 optometrists, clinical optometrists, and this has been a whole new departure. Prior to this, we wouldn't have had optometrists working in the community setup. So to do this, I had to set up standard operating policies and clinical care pathways so that everybody was comfortable seeing who they were seeing. Everyone knew who they were seeing. They were working within their scope of practice, and that was a big body of work. I also have an orthoptist, an ophthalmic nurse, and 2 healthcare assistants, and huge buy-in from the admin teams. And really, it was the game changer. So this allowed us really to push on, and we are now running up to 40 clinics a week over 3 centres. And we looked at our infrastructure because we didn't have enough clinic space. So we had to look outside the box. In the Galway area in Shantala, we actually divided a room, and this gave us 3 clinic rooms so we could run double clinics. And in Tuam and Loughrea, our other 2 centres, we got access to 2 clinics, and we went to a 5-day service in all 3 centres. So really, it's very clear we went from 12 clinics a week to up to 40 clinics a week. And surprisingly, we actually got on top of this waiting list within 8 months, which we actually didn't expect ourselves. Children now are not waiting for their eye clinic appointments.
Super. And we can see from the extra resources, more clinics. We can see from the next slide, as you described there, the extra space, the extra clinical rooms for these professionals to be able to carry out the tests, and investment in equipment and people, all really important ways of not you've examined the problem, and this is how you set out to resolve it, and restructuring is very much an important part of that. So what impact has this new care pathway, this modernised care pathway, what impact is it having on the waiting lists?
Well, in community, it's essentially eliminated it, but having achieved this, we then got involved with our tertiary referral centre, which is Galway University Hospital, and I'm lucky because I previously worked there. I know all the consultants well.
Always helps, always helps. Yeah, yeah.
Relationships are key to everything. And I go in one day a week. So myself and the consultants in the hospital, we set up a pathway allowing the paediatric children who attend for eye clinics in GUH. They are now up to 70% of them are now being discharged out to the community. So they also had a big backlog. This is now being eradicated. And we've also rolled it out to the paediatricians in the hospital. So now they refer directly to our service.
Right.
And children with additional needs who were being referred to Galway University Hospital, which is a very busy hospital and is probably not the most ideal setup for children with additional needs. They're now coming out to the community. And so this is the first port of call for all children for their eye clinic appointments, apart from those with acute problems or complicated needs. So it's allowing GUH to see the children they need to see, the children for surgery, acute care, and we're seeing everything else. And this has been really a game changer, both for PEDS in eye department in Galway and also out here in community. But again, as you said, relationships, in and out, I'm always in and out, know.
Yeah, and we see that across so many of these new innovative pathways, that it is about people who've worked together, who know each other, and who perhaps for years have been saying, God, if we could just do this and this, we'd make such a difference. And Sláintecare, I suppose, has enabled some of those connections to be made and the pathways to be opened. So in summary then, in terms of...
actually, Gráinne, we developed a second pathway then, which we rolled out actually in April, the cataract pre-assessment pathway. So cataracts were being pre-assessed. Patients with cataracts were being pre-assessed in the hospital. They were having 2 appointments, one to see the doctor and then to come back for their scans. We've taken this over, again, developed with the consultants in GUH, and we rolled it out from April of this year. So elderly patients for the first time, and actually adults for the first time, are being seen in community in Galway, and this is a whole new departure for us. And it's great because it's a one-stop shop. They get everything done on the one day, and then they get listed directly to the cataract list. So again, it's a really good example of integration between the two centres.
Fantastic. So in summary then, key successes, if you're to give me a 1, 2, and 3, what do you think have been the key successes of the new pathway?
Successes are eliminating the paediatric children's waiting list and making sure children are getting seen in time in the correct environment. Also supporting our regional centre, making sure that they have us to see basically the general children who we should be seeing. And then thirdly, making sure that adults in our area who have cataracts are getting seen in a timely manner in a one-stop shop, only one visit, close to home. And so really, we are really living integrated care.
Yeah, very much so. Well done, Dr. Comer. And I think those insights and indeed your presentation of them, very passionate, very exciting. And I know you can stay. You will be on the panel, and I would say that there'll be questions coming in asking you about that great work. So well done, and thank you so much for that, for those insights. Regarding enhanced community care, we are expanding our primary care capacity and community services to ensure that patients are treated in their locality, and we've mentioned already this afternoon, as close to home as possible is one of the principles. Alice McGinley is joining us now. I'm delighted to have her here. And Alice is the Community Healthcare Network Implementation Lead. And Alice will now share with us some of the progress that is being made in delivering enhanced community care. Alice, you're very, very welcome.
Good afternoon, everybody, and thank you, Gráinne. The enhanced community care has been mentioned already in our presentation there in the Sláintecare report. And I suppose the enhanced community care was the business case that was put forward for implementation of Sláintecare within the community. Right, move the slide, please. And the next slide will just give you a broad overview of what we are talking about. So one of the main focuses is maintaining people where possible in the community. It's referred to as shift left, but a lot of the resources and activity will be happening in the community, which refers to the right place and the right time. And then where possible and where necessary, there is access to specialist opinion. So you'll see on the left-hand side there, we're talking about population health profiling, and Tony referred to that, end-to-end care pathways, and then we have the 96 community healthcare networks and 30 specialist teams for older people and for chronic disease. And these all form part of the basis of teams in the community. They're then supported by our colleagues in the acute setting, but also with Pathfinder and really good examples of innovation out in different areas, such as the EDIT pathway, and also then our residential care facilities. So this gives a good broad overview of the enhanced community care. We'll move along to the next slide, please, in relation to where we are around delivery of the overall programme. Now this is quite high level, so the next slide, please. The resource allocation is really significant, both financially and in terms of additional WTs into the programme. We had a total of 3,500 additional WTs, of which 2,800 have been recruited to date. So that's significant achievement given all of the challenges we have within our system at this time. All of the 96 community healthcare networks have been commenced and are up and running and operational. And 27 of the ICPOP teams are operational, and 26 of the chronic disease specialist teams. So that's significant progress given all of the challenges we found ourselves in the health service within the last 2 years. In addition, there's also financial allocation for the GP access to diagnostics, and you can see 335,000 scans or radiology scans have been performed within 2023. And for some small scale survey that was undertaken by the ICGP, they did see a reduction in referrals to ED or to AMUs because of this access to diagnostics. So I suppose that's the coordinated and integrated part of the programme, which we will see as we go through it. The next slide, please. With this significant investment, I suppose more patients are being seen, and there's now a focus on productivity, on impact, outputs and outcomes. This slide just gives you an overview of the community healthcare networks, and at the outset, just to say that the data isn't as developed as some of the other specialist teams, in that the data is returned to the BIU as individual clinicians. Right. However, we are starting to collect our metrics here. And the CHNs are now providing the forum for improved multidisciplinary working, which is the reference there to the clinical team meetings. More patients are being seen for the first time. So we are seeing more patients, even though we have all of the challenges. And 39% more referrals have been accepted. The clinical pathways is really important for the networks, and also our GP colleagues are able to use their health link for referrals into the community services. So these are all really great progress in the networks, and we will continue to build on that. We'll move to the next slide in relation to the developments for the integrated care programme for older people. And what this has shown is that with the support of these community specialist teams, we are avoiding admission to the community setting or to the acute hospital, but they're being managed in the community setting. A number of patients or clients are being seen on the same day or next day, and they're being reviewed by the team for more urgent cases. And I suppose really importantly here is the fact that 74% of the patients seen by ICPOP had been discharged home. And the significant numbers that are being seen overall. So I suppose in summary, it's really important there at the start that GPs have now signed up to the CDM contract, and that's providing services for patients and clients in the community. And also we have a reduction in the 30 and 90-day readmission rates. So these were significant figures for clients, older persons, and also for clients with chronic disease to date.
Sorry, Alice, you've gone on to mute there. I don't know if you've accidentally pressed your mute button. Just unmute yourself. That's it. Off you go. Not at all.
We'll move on to the next slide. So please, the activity for 2024, the next, yes, this one. So I think as you see, you know, in terms of productivity and outputs, we are starting to increase our outputs and for 2024, and we have targets there identified, acknowledging all of the challenges that are in the system at this time. But still, there is a significant number of patients and service users accessing our services. We're moving on.
Sorry, Alice, you're gone back to mute for some reason.
Apologies about that.
That's okay.
Yeah. We'll move to the next slide, please. Some of the key enablers have been maybe referenced already. So we move to the next slide. So there had been some learning from the chronic disease implementation. The chronic disease program were new programs, and we were able to take the learning from those. So as we said, the GP agreement, the ICT enabled program, and the community specialist hubs to support GPs and the networks. That was really, really important in terms of helping us to maintain services in the community. And then you have digital enabled services, and they were able to have access to HYPE and other services, and integrating with our acute colleagues really assisted. So I know there has been reference to ICT requirements and digital development, which will be really important as we move through this. Okay. There is the interim ICT solution, and we're just successful vendor has been identified for this. So this is really another step forward for us that will help us in the community in terms of having the initial part of the ICCMS project, the integrated project in the community for ICT.
I have to move you along, Alice, I'm afraid. We're running out of time.
Okay. Area Finder then, I suppose, was really important in terms of identifying where all the services are available. And that was another really good development. Can we move on to the next slide, please? And the access to diagnostics and our capital supports then that money that was made available for additional clinical placements and clinical space. The last slide then, you'll be delighted. So into 2024, I suppose the piece is around supporting the shift from unidisciplinary to multidisciplinary ways of working is the real piece, and where the focus will be for 2024. Aligning the ECC with the UEC approaches on avoiding hospital avoidance and early discharges, population need and stratification, and then allowing for local innovation. And all of these will be important. And I suppose throughout all of it, it's really important to have a communication plan and to continuously communicate at all levels, particularly in time of such significant change as we had just heard earlier with the regional health areas and all of the other developments. Thank you, Grania.
Thank you so much, Alice. And again, this is such an important element in the delivery of care in the community. All of those networks, all talking to each other, all of them set up. And we have had many of the, I'm thinking of some of the older people's services, some of the chronic disease people who received funding under the Sláintecare Implementation Fund. We've had them and featured them to see the work as it was being piloted and now mainstreamed. So that's great to have that overview that you've given us. Thank you so much.
Thank you.
We're now joined by Dr. Sinead Walsh, who is a respiratory consultant and respiratory lead for the Galway City Integrated Care Hub. But before we go to Sinead live, as they say, we have a short video to show you.
I'm the respiratory lead here in Galway for the Galway City Integrated Care Hub. That means I have responsibility for setting up the Enhanced Community Care Programme for patients with 2 respiratory chronic conditions called COPD and asthma. Every Tuesday we come to my Cullen and we offer a one-stop shop for patients. When patients come to my Cullen, they get their breathing test done first by the physiologist. This is where we look at the amount of air that they can breathe in and out of their lungs. When that test is done, then they see me. And then with the results of the breathing test that they just had, I can make a diagnosis of COPD or asthma. The patient then goes on and sees our respiratory clinical nurse specialist and our respiratory physiotherapist. Prior to this, GPs would refer patients with a query diagnosis of asthma or COPD to the acute respiratory services. Patients were often waiting over 3 years to access that breathing test and to access a specialist. Now, GPs can refer directly to us in the Integrated Care Hub. We triage that referral and we will arrange for that patient to be seen in the coming weeks.
I came to the service in the early summer. I'm asthmatic and have been for the last 15 years. It's been an excellent service. I've been able to have that one-on-one service with the professionals. Just the convenience of being able to come out here as well, like, you know, with the traffic and the less anxiety about parking in the main hospital. The follow-up plan when I left was absolutely brilliant. You know, I left here with not having to return, having the proper inhalers, the proper technique and the proper equipment to use. From attending the service, I'm on the right path with my asthma. Overall, it's been an excellent service.
My role here is to ensure that all patients fully understand their diagnosis following consultation with the consultant. I go through the patient's treatment plan in detail. I look at their inhaler techniques and make sure they're doing it correctly. And I also answer at this point any questions that they may have.
My role is to educate and treat patients in airway clearance techniques, breathlessness management, restoring normal breathing patterns, and individually prescribing exercise programs.
This has been an absolute game changer for patients. Previously, they were waiting a number of years to even access a respiratory specialist. Now they know they'll be seen within a number of weeks. They can see us here in the Mycullen Primary Care Centre. They have no problem parking, and they can get a diagnosis and a treatment plan all in one visit.
That's a super video. Thanks so much, Sinead, for that. So you're delivering the integrated care as part of the integrated care programme for the prevention and management of chronic diseases. Can you tell us about the background and the impact of the Respiratory One-Stop Shop Community Clinic, Sinead? You're very welcome.
Thank you, and thanks for the invite. So we'll go to the next slide, please. So previously, I suppose, every patient had to come in through the front door of the hospital. So they'd have numerous clinic visits. They'd have to see the consultant first as a new patient. They'd come back another day to get that breathing test. And then they'd have another review appointment with the doctor with the results of that breathing test. And then another review on a different day with the nurse and the physio for their input as well. So now, as you saw on the video, we do our one-stop shop clinics in the community, and that's bringing care close to where the patient lives. So I'm working in the Galway City Integrated Care Hub, so that's covering a very geographically dispersed area, including Connemara, Galway City, and then the east side of the city as well. So you can see the red dots there, that's where we do our one-stop shop clinics. It's bringing care close to where the patient is, exactly as per Sláintecare. So we'll go to the next slide, please. So as you saw in the video, it really is patient-centered care, and the clinic is built around the patient. And the patient will receive those 4 clinical encounters at the one visit. So the physiologist first, then myself, then the nurse specialist, and then the physiotherapist. Next slide, please. So we're up and running just over a year. And in that time, we've seen over 300 new patients. So when we opened our doors, we actually didn't have any GP direct referrals. So we pulled patients off the existing acute hospital waitlist. And we continue to pull off the acute hospital waitlist. And if the referral is a query or an established diagnosis of asthma or COPD, and they're within our catchment area. But over time, we've engaged with GPs, they know we're up and running. So actually 58% of our referrals now are directly from GPs to us in the hub. So that's over 150 patients that have avoided going on any hospital waitlists altogether. And of course, we take referrals then as well from our ECC colleagues, so our cardiology and diabetes colleagues, and our older persons colleagues as well. So 66% of the referrals that we get would be a query diagnosis of asthma or COPD, and then 33% would be a diagnosis for optimization. So with that one-stop shop model, I'm able to discharge 87% of patients after that one visit. So I can see them with the results of that breathing test, make a diagnosis, and get them on international, treatment based on international guidelines. And that keeps capacity in the system for me to allow to continue to see new patients in a timely manner. And the respiratory nurse specialist will follow those patients up then in 6 weeks' time again to ensure that they're doing well. And they have a 90% discharge rate at that stage. So that's really good.
Fantastic, yeah.
And then just to say as well that of those who get a diagnosis of COPD, Over 50% of those are referred onwards for our community-based pulmonary rehab programs. And pulmonary rehab is brilliant. It's an 8-week program of exercise and education for patients, and it has been shown to improve their quality of life, reduce COPD exacerbations, and also reduce hospitalizations for COPD exacerbations in the future. So we will start to see the positive effect of that down the line. Next slide, please. And we are seeing the positive impact on hospital wait lists. So as I said before that, previously patients would have been waiting up to 3 years to access a specialist. Now they know they'll be seen and accessing a specialist. And our average wait time at the moment is anywhere from 4 to 6 weeks. So that's great. Next slide, please. What are the learnings to date? I suppose what works well is teamwork. We're an interprofessional team, and that weekly MDT where we all come together and discuss referrals, but also to discuss in cases that we've encountered over the week. That's really good, that interprofessional learning. The Secretary General mentioned GPs and consultants working together, and that's absolutely vital from what I've learned over the past year, that regular GP engagement, both formally through CME meetings, but also that informal GP engagement as well, is essential. So I heard that they thought my letters were a bit too long. So I've just taken that feedback on board, and now I've tweaked my letter to put the diagnosis and the action plan at the start of the letter. So I just think that engagement is essential. Governance structures, we have our monthly ECC steering committee meeting. That's really, really important as well for adequate governance. And obviously we've our improved wait times and our satisfied patients. Areas to work on, it is an information overload for some patients, and we have to be mindful of that. That we just need to know that when is enough, and maybe we do need to separate it into 2 visits for some patients, but that's absolutely fine. We're very much a patient-centered service. If a patient doesn't come, that's really frustrating, because if you build a clinic around patients coming, and I suppose in the acute hospital you needed a few DNAs to keep the clinics working well, but if patients don't come in the community, it can be a little bit frustrating. And then obviously resources, we've touched on these already, but admin, ICT, I acknowledge there is progress being made there as well. And there is a national shortage of respiratory physiologists, so that workforce planning is essential as well, but also the recruitment embargo. It'd be terrible. Well, what's actually happening is that we're training respiratory physiologist students in the public system, and if we don't have employment to offer them in the coming months with the embargo, it would be frustrating to lose them to the private system. So that's everything for me. And
that's great. Thanks, Sinead, and really, really interesting and effective service there. And that idea of the one-stop shop, even simple things, and this has come up in the webinars before. People just driving their car to one place, not having to pay parking, not having to be driving around huge car parks, competing with people who are trying to get into emergency departments. So even though those things seem small, they really make a difference to the mindset when people walk into you to do their test, to be seen. They're more relaxed, all of those things. So well done. It's great. Thank you so much for that, Sinead. So moving on to our panel discussions, we're very tight on time today, but I do have a couple of questions and a few comments that have come in. So welcome back to Grace and Geraldine and Alice and Sinead. You're all very welcome back. Grace, I want to go back to you briefly. There has been great progress over the last 3 years, but what governance is in place to ensure the delivery of Sláintecare? You just unmute still, just unmute yourself. There you go.
Sorry, Gráinne. Yeah, thanks, great question. So the programme board was set up at, I think it was the end of 2021. The programme board is chaired by the Secretary General, who you met earlier in the webinar, Robert, and the CEO of the HSE, Bernard Gloucester. And the members of the senior members of the department within the department and the HSE responsible for the Sláintecare programs and projects sit on that committee. It meets every couple of months. And then the project leads for each of the projects and programs from the department and the HSE meet at the Sláintecare Program Management Office. It's secretary to the Program Board, so we manage their work program and support their work, and we also work with the project leads. So that group also meets, convenes in advance of the Program Board, and each of the joint project teams would work jointly on their projects as time goes. So there's a very programmatic approach to each of the projects.
Yeah.
The Programme Management Office develops the action plan every year with the projects, and we report on their progress. So it's very implementation focused. I mean, the policy, I think, is quite clear. And I think one of the distinguishing aspects of the Sláintecare programme is that it is strong in implementation, and the programmatic approach taken and the leadership shown by the Programme Management and the Programme Management Board, and the very visible leadership of both the Secretary General and the CEO. It's very proactive, positive, dynamic, and it's very much a model of collaboration as well.
Yeah.
So that the teams are working well together. Yeah,
that's great. Thanks, Grace. I don't have a lot of questions coming in, but some of them that did come are Rosie will answer them separately. They're more kind of operational things, but lovely comment for some of you. Thomas says, an incredible success story from Dr. Comer at such a vital point in children's lives. Well done. So Geraldine, clap on the back for you there. Your work much appreciated. General comment, great eye health care service in the Galway community. And then after Sinead's presentation, fabulous presentation, really informative. And then for all of you, excellent presentations this afternoon, lots of good work happening. And Marion, great to see so much work being done to bring care to local communities. Well done to all, and thank you. And I am afraid we have come to the end of a very busy hour. It is 4:30, and I know people don't like to be kept on when they've just joined us for an hour. Thank you, each of you, for your preparation, for your presentations this afternoon, for the conversation. Thanks to all the guests here today, all the panelists, and those who joined us earlier on, all the team here who helped to produce this session. A special thanks to Rosaline Harlan for all of her wonderful work on all 24, 24 webinars. And as always, a big thank you to our technical support man, Tom Duke. You can watch this webinar back, recommend it to your colleagues. It will be available on the Sláintecare website. So from me, Gráinne Healy, until the next time, continue to stay safe, and thank you all very much. Well done.